Good morning. Nice to see you all here this morning. Beautiful day. I guess people are outside enjoying the weather. Um, this is our kickoff event for this year's Moments in Grand Round series, lectureship leadership series, and we're very fortunate to have on our faculty here Richard Sewell, who's going to be our kickoff speaker. And as I was reviewing everything, I was saying to Richard outside before over coffee, as I reviewed everything he's done in his career, it's really amazing. I don't know how he finds time to do all this stuff. So he really knows an awful lot about about healthcare systems and public health. And let me just remind you of a few of his accomplishments. He was executive director of the Health Systems Agency for Cook County and DuPage County. He was founding president of the Suburban Primary Health Care Council, Providers Access to Care Program, Deputy Commissioner of the Chicago Department of Public Health, and Executive Director of Chicago Health Policy Council at the University of Chicago before coming here. He's also Senior Vice President of United Way in Chicago, and he's currently working on as Principal Investigator on the development of a regional plan for health as part of the GO-TO 2040 plan of the Chicago Metropolitan Agency for Planning. And that's just some of the highlights of what he's doing or has done. So you can see that Richard has a long, rich, deep experience, and he's going to share some of those thoughts with us today, talking about leadership requirements for new starts. Richard?
Well, good morning. Thank you very much, Dean. I understand that at the end of the prepared remarks, there'll be time for comments and questions from you, and I hope that some of you that have been engaged in what I'm calling new starts, organizations that didn't exist before you got there, will sort of share some of your experiences. I want to share some of my management career experiences with organizations at various stages in their organizational life cycle. My purpose is to explore the question of leadership requirements for organizations in early stages of development and to encourage you to think about the differences for organizations in later stages of the life cycle. Some of you are familiar with the work of Ishak Adiz. His work is called, well, one of his books is called Corporate Life Cycles. That's the one that he's best known for. And he outlines his notions about organizational life cycles and their characteristics. This is sort of a representation of how Adiz sees the various stages of organizational life almost equated to the human life cycle. There's the courtship, which could just turn into an affair. Might not produce any offspring, and then maybe it could. And then there's infancy, and some organizations don't even make it through infancy, therefore infant mortality. The go-go phase, where there's a lot of energy and excitement and sometimes chaos, that can fall into what he calls the founder or the family trap, where the interest of the energetic person behind the organization either wanes or they get distracted by something else, and that's a pretty risky phase too. Then you move into adolescence, when the organization is becoming known and is a little more sure of itself, but there's a lot of threats to that, like the human stage of adolescence. Divorce is a threat to children who have reached that stage. Premature aging, unfulfilled entrepreneur who gets distracted and moves on to something else. Then prime and stable, those are phases where the organization is really pretty much at its best. In terms of stable, though, you do begin to see and you're able to identify some of the challenges that do occur even to organizations that are doing well. And you'll notice this is like an incline and then a decline in terms of the shape of this curve. So you move to aristocracy, early bureaucracy, and ultimately death. In some of Adiz's work, he also uses the term recrimination for early bureaucracy. To give you a little more of the descriptions, think I've got that on the slide too. Yeah, here we go. Courtship. That's the model stage, the creation of the proposition for the organization, even before it begins. Then infancy, it's already launched. It's gotten started. So some of the terms you see up here may or may not apply to not-for-profit and government, but they're intended to be somewhat general. The go-go phase I mentioned before, the energetic early growth, and there's a lot of chaos at that stage too. Adolescence, organizations still maturing and growing, but it's more established than it was in earlier phases and more well-defined in terms of its, in terms of the enterprise. Prime, this is it. At your fittest, your healthiest, and you're most competitive. You're popular and you're profitable. Stable, all of those things apply, but you're beginning to lose a little bit of your edge as an organization, and there are some identified and perhaps some unidentified vulnerability to what's going on in the external environment. Aristocracy, you've got this market presence, you're strong, you've got a chest of successes, but you know, you're not very interesting anymore. You're slow. You might be losing market share. You might be getting behind in terms of trends and technology. Recrimination, which is also on the other curve called early bureaucracy, a lot of doubts, a lot of threats, problems, issues, and they're beginning to overshadow your reason for existing. Bureaucracy, very inward-focused administration, cumbersome, maybe trying to offload some of the components of the enterprise. Then, of course, like with humans, death, closure, sell-off, bankruptcy, bought for your asset value. All you have is a small customer base. My management career prior to joining the faculty at the UIC School of Public Health and the roles that I played and the organizational life cycles that those organizations were in are here. From about, when was it? Good gracious, 1968 to 71, I was at the Toledo Health Department. I was a supervisor. I would describe that organization and then the one immediately before coming here, United Way in Chicago, as being at the recrimination or early bureaucracy stage of their life cycle. You know, it's a health department for what was at one time a fairly major city, I think the 49th largest city in the United States. And then United Way was about to go into a merger and become what is now the United Way of Metropolitan Chicago. So I sort of classify them as early bureaucracy. Both of the health planning agencies I worked at, the one in Northwest Ohio and the one for suburban Cook and DuPage that the dean mentioned, those were the go-go organizations. Those were organizations where there was a high level of activity, there was a lot of energy. There was also a lot of chaos because some of the communities really had not bought into the idea of planning being centralized at the regional level. This was especially true of suburban Cook and DuPage County, where there had been no history of regional planning. There had been a history of regional planning in Northwest Ohio, but there was still a lot of excitement because there was a new federal law, the Comprehensive Health Planning Act, that supported that. The aristocracy was clearly the Council for Community Services in Metropolitan Chicago, where I stayed for all of 10 months. They kept waiting until the merger was finished before they could do something. And I don't know if any of you have ever worked at a place where there was nothing to do, but a day seemed like it lasted about 14 hours. You couldn't even get from starting work to lunchtime without, you know, thinking of your whole life, calling your wife, you know, that kind of stuff. I mean, it was just crazy. But that clearly was an aristocracy, and when the merger occurred, those functions were, they went away that this organization was carrying out. So it quickly went down that decline that you saw in the D's illustration. The Hay Group was stable. I stayed there 5 months and 7 days. So one of the ways I do all this stuff, I don't stay there long. But I've been here a long time. The Hay Group is a international consulting firm that deals with reward management and benefits. And if any of you have ever looked at want ads in the human resources section for compensation analysts or whatever, they say must know the Hay system. The Hay system is sort of the language of human resources. They had a very stable group of clients. They were very competitive, and there was no sign of them losing market share by any stretch of the imagination. The two organizations I'm going to focus on today, I use the term new starts, which I'm going to equate with Adiz's term of infancy, would be the Suburban Primary Health Care Council, organization that operates the Suburban Access to Care program, and the Chicago Health Policy Research Council, which was at the University of Chicago. When we talk about leadership requirements for governmental and not-for-profit sector organizations, we first have to agree on the end or the reference point that serve as the destination for those requirements. Like, where are we going in terms of the application of leadership requirements when we think about the governmental sector and the nonprofit sector? We can probably agree that the end is, of course, successful accomplishment of organizational objectives. However, a more fundamental goal for purposes of our discussion today is sustainability. If you can't sustain the organization, you're not going to be there to even attempt to achieve organizational objectives. You must survive. The issuance of tax-exempt status, the 501c3 and the other categories by the Internal Revenue Service, outpaces the growth in philanthropy. So what this means is that the likelihood that survival is unlikely for every charitable organization is real. Everybody's not going to make it. The philanthropic pie is not growing as fast as the issuance of tax-exempt status by the IRS. So there are more and more competitors every year in that sector. Peter York, who's Senior Vice President and Director of Research for TCC Group, that's a consulting firm, presents a sustainability formula where leadership plus adaptability plus program capacity leads to sustainability. I want to talk about, before I talk about the leadership bubble, let's talk about what he means by adaptability and program capacity. For adaptability, you've got the stakeholders being invested in the program. Somebody cares about the organization. It could be clients, it could be funders, it could be the government, but somebody cares what happens. Usually organizations that accomplish this adaptability challenge have some long-term relationships with leadership and with funders. They've got history with them. There's a comfort level between the two. They usually have sophisticated financial management practices where there's proper oversight by senior managers and by board members, and they are on top of the more modern approaches to managing that fiscal asset. Failure to do that, of course, is a huge threat to sustainability. They have data about trends and external forces. They know what's happening outside their organization in the external environment that impacts their product or their services. And they pay attention to that and they monitor that. They have data, they have the capacity to do program evaluation. They check to see whether things work rather than saying, didn't we do a good job on that? They hold it up to benchmarks and to standards, and they're self-critical, and they make changes as a result of evaluation findings. And they have managers that will act on data. In other words, once something is known, they make a move to do something about it. So that's the adaptability piece. The program capacity is much simpler. It's really that you have the staff resources and the facilities that are required for efficient performance. So those are the two. Those are the two bubbles that we're not going to talk about so much as this leadership bubble. Here's what Peter York from TCC Group thinks are the leadership requirements for organizations. That they would have a clear mission and vision, and then on top of that, an ability to motivate other people beside themselves, besides the immediate beneficiaries of the service, to the mission and the vision of the organization. They take decisive action in response to challenges. When something comes up, they take action. They deal with it. They have the involvement of their key stakeholders in their strategic planning process. More importantly, they do strategic planning, and they have a strategic planning process, and they engage key stakeholders in that process. And then they have accountability for demonstrating the success of their planning. In other words, they hold themselves accountable to the strategies that they develop and to the findings that they have in terms of looking at the external forces and the impact that that has on strategic planning. Now, in order to explore the unique leadership requirements for new starts, I want to use some of my experiences with the two organizations that I placed in the infancy stage of Adiz's corporate life cycles and see what we come up with. The Suburban Primary Health Care Council. This organization got started in 1987. It currently operates the Access to Care program in suburban Cook County and in two sub-areas of the city of Chicago, on the northwest side and the southwest side. The organization was founded by four suburban agencies that had independently, separate from each other, pursued funding from the Chicago Community Trust under the Healthcare in Cook County initiative that the trust had in the mid-'80s. These organizations were actually told by the Community Trust Senior Program Officer for Health that they should submit one proposal. So it was sort of this shotgun wedding that occurred, where these four different groups had to come together and come up with one proposal. I was hired, and with the help of one of my senior planners who had worked with me on my prior assignment at the Health Systems Agency, we designed the Access to Care program. The program basically provides primary care services to clients who don't qualify for Medicaid and are under 200% of the federal poverty level. Radiology services, laboratory services, and pharmacy services are also included. There are co-payments for these clients because these are the so-called working poor. So they have some resources. There are capitation contracts with primary care physicians. So after 22 years, Access to Care still exists as a sustainable program. Let me go back. The other organization I put in the infancy stage was the Chicago Health Policy Research Council, which was launched as a health policy research enabling mechanism at the University of Chicago. This happened in 1993. I served as executive director. These are the functions of the Chicago Health Policy Research Council. To establish a health policy research agenda for Chicago. What's the set of policy relevant health services research that needs to be done in Chicago and about Chicago? Recommending to the funding source funding of policy relevant studies with good research designs. Policy relevant in that they fit with the research agenda, and then good research designs because they had to meet the test of being good research, but they also had to show that they were policy relevant. We conducted a monthly downtown health policy series which was a speaker series to talk about issues that we cared about in terms of our research agenda. And we were able to develop a cadre of health policy professionals by having resources for postdoctoral fellowships, pre-doctoral fellowships, and even master's paper awards. If students wrote a paper on a topic that was relevant to the research agenda of the council, it was submitted to a faculty panel from various universities. The student's name and where they were matriculating was not made aware to the panel, and they could get, I think, up to $1,500 for a good paper. And then we had an academic consortium, and this was no more than a meeting of faculty researchers from all the universities to talk about what some of the barriers were to doing policy-relevant health services research. After 3 years, 26 research projects had been funded, and other functions were also going very well. The key funder, however, who controlled the resources for research funding, announced with glee, actually, that their restricted funds for research were exhausted and that the council should develop a new mission. I think the words were, "We're out of research money, but we like you guys, so figure out what else you can do and we'll fund you." So a decision was made by the council leadership and by me as executive director to assume the function of monitoring changes in health and health services in Chicago and publishing and selling subscriptions to a quarterly report. I think it was called the Chicago Healthcare Report. That was for leaders and for policymakers. After another 3 years, the council ceased operations. So it had a life of about 7 years. And there is no such thing anymore as the Chicago Health Policy Research Council. Actually, we changed our name to the Chicago Health Policy Council when we stopped doing the research and started monitoring changes. So one of these organizations still exists, is still a going concern, is operating a program that's actually growing, and the other one ceased to exist. It's kind of scary for me to get up here and say all this stuff, because the one that failed, I was the executive director. So, maybe it's my fault. But I certainly learned from that. Let's look at these leadership requirements that the fellow from TCC Group gave us and sort of make some observations about what happened with the Suburban Primary Health Care Council that operates access to care. In terms of clear mission and vision, I rated them as pretty good on that. Providing primary care services to medically indigent individuals living in a large, geographically dispersed area is a compelling mission. In terms of the ability to motivate others about that vision, a couple of points. After a pretty slow start at the beginning when the program was launched, physicians started to sign capitation contracts. One of the things they could do with these contracts is control the panel size of medically indigent patients, and they could assure a revenue stream. For patients who were not covered by any third party, they may get paid and they may not. You sign a capitation agreement with the Access to Care program, you're at risk for seeing a defined panel size of medically indigent people, but you're going to get a capitation payment based on the actuarial risk, just like an HMO works, of seeing them. So that made a compelling argument with the physicians. We actually went around and talked to medical staffings at hospitals, the primary care physicians, and that's what got things going. But it was a slow start. The County of Cook eventually viewed access to care as a mechanism to improve the balance between property tax revenue from suburban Cook County and visible health programs for suburban residents. In other words, you've got all this property tax revenue coming in from people who live in Cook County outside the city of Chicago, but most of the physical presence of the county's health system is in the city of Chicago. So access to care became this political mechanism where, look at what we're doing. We have this innovative program that was written up in JAMA, and we're doing things. We don't have a building, but we have a program. So I rated them good on, motivating others concerning their mission and vision. In terms of decisive action in response to challenges, I gave them sort of an okay. Municipal and township governments in suburban Cook County were asked to support their calculated population of medically indigent residents. In other words, you figure out how many people there are in, Oak Park Township, and then you multiply that times the cost for their capitation coverage, and you ask the township to give a grant to Suburban Primary Health Care Council because, these are your people. Even if some declined, and many did, the ask presented the philosophy that government was responsible for those residents. So even when they said no, you had sort of planted the psychological seed that, you're responsible for these people because here's the number of people that fit into this category. In terms of involvement in strategic planning, a strategic plan was developed, and a key Cook County commissioner was recruited to the board of directors of Suburban Primary Health Care Council, who became a champion for county funding. Without her presence on the board and her indoctrination to the Access to Care program, I don't think the County of Cook would have picked up the funding of a new program operated by a private not-for-profit organization. And then accountability for demonstrating strategic planning success. The council used that calculated number of medically indigent residents as a way to implement the strategic plan policy of expanding from a demonstration program to one that operated in only a few townships in the suburbs to a county-wide program. When we first started, we had 2 townships in South Suburban Cook and 6 townships in Northwest Suburban Cook. Based on expanding the funding from townships and getting county funding, it's now all of suburban Cook County, and then a few areas in the city of Chicago where there's no presence of federally qualified health centers. So that's just my assessment of how this new start responded to some of the leadership requirements. Now, the Health Policy Research Council, in terms of clear mission and vision, I rated them good. The council had a strong case regarding the weakness of research findings that influence health policy decisions in Chicago. There's probably no place where health policy decisions are the sole prior question for policy decisions, but they were perceived as even weaker in Chicago and in Illinois. We thought of ourselves as being the area with the smoke-filled rooms. That's how we make decisions here. We're not ready to look at all that data and policy analysis. So that was a strong case. A scarcity of health services research about Chicago. We found that we've got all these faculty members doing research at some pretty impressive universities, including this place, but they tended to, at that time, study other geographies. You would have these big studies coming out of here and Northwestern, University of Chicago, but they're talking about Northern California or Minnesota or Louisiana. So we felt a presence and a rich supply of health policy professionals at our area universities, but they weren't looking at Chicago. So the council became this mechanism to solve that problem. In terms of motivating other people about that vision, when we talked to each other, this sounded really good. But getting other people excited about it, there were a few problems. The council was located at one university. I was a University of Chicago employee, okay? And the University of Chicago competes for scarce resources for research with the other area universities. So if you're at any place other than the University of Chicago and you hear about this, you assume you're not going to get a fair shake. You assume that Chicago's going to suck up all this money and there isn't going to be any for us. The major funder, which was the Chicago Community Trust, was uncomfortable with funding research. You know, the Chicago Community Trust doesn't fund a lot of research, but they had to do this because they had a family fund that was restricted to funding research. So they had to get rid of this money. All right? The council, we did not have direct control over the allocation of research dollars. We advised them that this is a good project that fits our agenda, that is policy relevant, so you should fund it. But it's not as if we made that decision and then we wrote a check. We didn't have that money in our budget. We only had money in our budget to support our staff. And then the council was viewed as a program of one local foundation. Other local foundations said that's that program that belongs to the community trust. So why should we get involved in that? So I think marginal on motivating other people to our mission and vision. Too many issues in the design. And then decisive action in response to challenges. The decision to form that academic consortium was very good because the council was able to increase the perception of objectivity in spite of its location at one university. The reality is that Chicago didn't get most of the research money because they don't tend to do policy relevant research at Chicago like they do here and at other places. So they just didn't. We turned them down. I mean, I always felt like I was going to get fired. Instead of that, I got laid off. Involvement in strategic planning, I think that was marginal. We did not have a broad base of local philanthropic organizations that we recruited for involvement in our strategic planning. I think we did not respond to that one very well. And then the last one, I thought, good. The Robert Wood Johnson Foundation's senior vice president for research was the only council member who was from outside Chicago. At that time, it was Dr. Jim Nickman. And he was on our council, and he partially paid for an independent evaluation of the council. So we had, that was a good thing. We had developed a strategic plan, and we had this really positive independent evaluation. The assessment was that we were accomplishing our objectives. From those experiences, I can speculate on what the leadership requirements are for organizations in their infancy. Here's what I came up with. Obviously, you've got to tailor your design specifications. The requirement must be tailored to the design specifications of the enterprise. In other words, you can't have a mechanism that funds research by faculty researchers at every university in town located at one university. That's just, that wasn't smart. You want to avoid structures and organizational homes. This is sort of a different variation on the same theme that create the perception of conflict of interest. It was the University of Chicago's idea. It lives at the University of Chicago, and the University of Chicago has the ear of the funding source in terms of who gets those research dollars, who gets those postdoctoral, predoctoral fellowships, who gets the master's paper awards. Now, time may have proven that there was objectivity, but initially you're starting off at a bad place. You want to get resource investments from philanthropic sources that are comfortable with whatever your core function is. If your big funder is not comfortable with what you're doing, then it's just a matter of time. So you've got to talk to federal government, and we did, and we got some money from them, but if we'd been about 2 or 3 years later, CDC all of a sudden became interested in performance monitoring, but we'd already closed by then. You have to be able to control the allocation of resources that are critical to accomplishing your mission. If you are paying for a response to a research agenda, you got to have the money in your budget to do that. Otherwise, someone may have the agenda of doing a run on the fund so that they can stop having this as one of their accountabilities, and that's a problem. You want to get a broad base of funding and involve more funders in your strategic planning process. That's something that a lot of us don't do. A lot of not-for-profit organizations don't do that. But even going beyond the people that currently give you money, get them involved in your strategic planning. And when you have positive evaluation findings, you've got to aggressively use those and get those out to people to demonstrate your effectiveness. Organizational stability, or organizational sustainability, that is, for new starts is enhanced when managers and stakeholders are actively engaged in these types of additional requirements that go beyond just the general leadership requirements for organizations that might be in a later stage of the life cycle. I'm going to stop here and see if you have any comments or questions about this. Yes. I think so, although, to be honest with you, there are some really practical problems with a mechanism like this being located at any place other than a university. Universities are set up to support research. You would have had to create a very special kind of mechanism that maybe was controlled by some kind of holding company that represented the interests of several universities, so that it was perceived as belonging to the community of researchers. The academic consortium that we created had that, but it was not a corporate entity. It wasn't anything that had staff except our support for it. But yes, that's a long-winded way of saying yes. I think had it not been there, I think we could have probably moved more quickly into this being a going concern. Sure. Yeah, right. Yeah. I think that's very challenging. Um, it's almost considered inappropriate to be so focused on survival and sustainability that that's all that's driving you. Somehow, it's sort of like your aspirations and beliefs and your character as an organization. I think of it like people. If I really believe in something, I've sort of got to walk the walk and talk the talk so that people who meet me will know that that's where I'm coming from, and it'll be compelling for them, even if they don't believe exactly the same thing. It's tough to do with an organization, but you're exactly right. If you get perceived as being successful only because you eat and sleep sustainability, that sounds sort of crass, doesn't it? I mean, it sounds like maybe you don't care about your fundamental mission. All you want to do is be here in the next 5 to 10 years, and it's got to be more to it than that. But one of the things, I see some of my former students in HBA 400, I always ask them this: what do you do if you're a hospital administrator and there's a disaster in your front yard, say the L or something? Do you send staff out there, rush to respond, stabilize them, treat them, or do you do what I call a wallet biopsy and stabilize them and send them to either a public hospital or a teaching hospital? And, there's no answer to that question because, you know, you get students that will answer it one way or the other, and I tell them they're going to get fired no matter what they do because their board is going to look at the books and say, we didn't do well during that period because you let all these people that we don't know anything about use our resources. And a lot of them were unsponsored. On the other hand, the cameras were rolling. And we saw your staff out there interviewing people who were bleeding to death. Do you have Blue Cross Blue Shield? And that's not good either. So you get fired. And that's where the answer has to come from the board and the leaders who run the hospital as to who they are. And they have to communicate that and infect other people with that notion of their self-identity so that they can accomplish their mission. Yeah. When we did get other funding, we got it for, let me give you an example. We got it for programs where their identity and their uniqueness could come through even though they perceived us as a Chicago Community Trust organization. I'll give you an example. We got money from the Michael Reese Health Trust, but we got it for a subset of those Downtown Health Policy Series lectures that they named the Sigmund Edelstone Series. So those tended to be special series with really prominent speakers that we would bring in. But see, they're on all the flyers and the paperwork supported by the Sigmund Edelstone Fund or the Michael Reese Health Trust. So even though this thing belonged to the trust in their minds, if we could work out a way where they could get credit and be identified as supporting some aspect of it, fine. The Agency for Healthcare Policy and Research supported a major conference that we had. So we could get pieces of it funded by other entities, but we could never get that core support. And of course, our organizational home never put any money into this. University of Chicago, they weren't going to fund this, especially since we had turned down several research projects for the University of Chicago. Yes, Jason. I think so. And I don't think that the conversations that occurred early on in the creation of this concept included any significant conversations about sustainability. I think that we had the Sewell family, the pharmaceutical family, that had restricted funds that had to be used for research. And the trust spent a couple of years trying to come up with a clinical research funding package and could never make that happen. And two professors at the University of Chicago came up with the idea for let's enable policy relevant health services research, let's improve the data access that researchers have. I forgot to put that up as a function. But nobody ever said, and this thing will sustain itself by fill in the blanks. It was just never there. Those subscriptions that we sold to that quarterly report, the revenue came in pretty good, but not enough to cover the core cost of doing the work on it. It just wasn't there. It was a good idea. We had a balanced scorecard of indicators on the front page where every quarter we'd say how much something had gone up, gone down, or stayed the same, and then write an article about the policy implications of those changes. Yes, sir. that is a huge leadership challenge, I think, for whoever is going to assume the chair of that board that has those four entities that were forced to get married, and then whoever's going to lead the staff. I think it's a major leadership challenge. The money was a pretty good incentive. It's either do or die. We're not going to fund four things in the suburbs, the trust said. We're going to fund one thing. So that'll get you going for a few months in terms of everybody behaving. But beyond that, I think it's the compelling mission and vision of we're going to offer something that everybody's talking about but nobody's doing. We're going to take care of part of the problem of these people who fall between the cracks. That was really a compelling vision. And we're going to do it in the suburbs because many health and human services providers in the suburbs have been trying to make the case for years that we've got poverty out here. And the reason why it's so hard to make the case is that they don't have them located in one little geographic area where you can point to that. They're dispersed. So the solution in terms of increasing access to care probably was not to develop clinics, because where would you put them? If the population is dispersed and you've got this vast, so Cook County is huge as a geography. I think it's one of the biggest counties in America in area, second or third, I don't know what. But the point is that the mission and the vision of the organization was sufficiently compelling that it contributed to some tendency to behave a little better. And then, because we needed a lot of data to support the model, in other words, to design this thing, you had to do counts, you had to hire an actuary to figure out the capitation thing. Everything sort of moved more over into the factual realm, and that was somewhat compelling too, because when there was conflict, you could almost fall back on that a little bit. Now, that's not to say that there weren't problems. When you start off as a demonstration program, you got 6 townships in the northwest suburbs and 2 in the south, and most of the need was in the south and the west. It's a problem moving from demonstration to countywide, because we were better able to get resources from townships in the northwest suburbs than we were in the southern suburbs. So there were still problems, but we had great leadership in the chair, and my associate and I had been at the Health Systems Agency, and there was really bad weather at the Health Systems Agency. There was conflict every time there was a committee meeting or a board meeting. So we were used to it. Nothing fazed us. As long as people didn't hit each other, it was okay. Yeah, that was our standard for decency. Yeah. Yes, ma'am. Yeah. You know what really helped me and Carolyn Trees, who was my senior planner, the health planning experience. You give people the components of something to work out on, and then things like mission and core values and all that evolves from that process. We've done that thousands of times with other issues. Some of the New Start challenge is not leadership, though; it's more management. Like, you have to do a benefit program. You got to create a corporation. The Suburban Primary Healthcare Council was not a corporate entity, and we were getting paid through Harper College in Palatine. So we had to incorporate, we had to get tax exempt status, we had to set up benefit program, retirement program, get a place to live. Alexian Brothers let us live with them for a while. We had to get our own office. So a lot of that stuff didn't have that much to do with leadership as it did management. But the leadership challenges were what the gentleman here was talking about, like making this marriage, work when nobody loved each other, So I think that I think the products that led, and then engaging early in a strategic plan. That was a smart thing to do because you got to talk about all the issues and put them right out there on the table, and you're going to have to make a decision, or else you're not going to have a strategy for key components of your program. And there were even disagreements about what was in and what was out in terms of primary care. The model was launched and was admittedly fragmented because there was no ambulatory specialty care in the model. And you have people in the suburbs, so where do you get ambulatory specialty care if it's not included? Well, Fantas is an ambulatory specialty care resource. That's downtown almost. That's right over here. So you're in Palatine, you know, you're in Phoenix. It's a problem. Yeah. We used to think that about management and leadership, you know, the great man, great woman theory. But we're finding, I mean, you're sitting near Dr. Rowitz. We have a leadership institute here. We sort of think that you can study leadership. You can develop as a leader yourself. You don't have to, you didn't have to be the person on the playground that everybody reported to when you were a kid. You know, there's some things that have come out of the experience of studying leadership where you can actually prepare yourself to be a leader like you can prepare yourself to be a dietitian. You know, you can do those things, and we believe that. The same thing is true of management. We used to think about management as being like the great man theory. You know, that's all it was. You know, well, we know that person's going to run something because they dominate recess in the third grade. You know, it doesn't work like that. We borrow from the behavioral sciences and from applied mathematics, and we learn that, and then we can do it. Yeah, doesn't mean you don't need mentors and, you know, role models to look at, but I really believe that the greatest preparation that I had was my involvement in health planning. Health planning was actually kind of scary because you had people who were your stakeholders who really came to the table to protect their vested interests. But yet they were supposed to produce a plan for a community who had residents that weren't at the table in many cases. And that's a very complex leadership challenge. So if you can do that, you can launch a good program like Access to Care. You can enable policy research. It's easy. You just can't sustain the policy research. Okay, thank you all very much. All right.